No, I am not going to pick you up.
Okay,
Great. All right. So we're going to go over the airflow pathway first. And there's some blank spaces for you to fill them in your lecture notes. But you go through the nasal cavity to the pharynx, which includes the nasopharynx, oropharynx, and laryngopharynx, to the larynx, to the trachea, to the right and left primary bronchi, to your secondary bronchi. You have 2 on the left and 3 on the right. Tertiary bronchi, terminal bronchioles, and then respiratory bronchioles, and then alveolar ducts and alveolar sacs in the individual alveoli. So I'll give you a second to write all that down. Yes?
Is this one updated lecture notes on Canvas?
It should be, unless if it's not, it looks different, let me know, and then I can update it. Oh yeah, all the pre-lecture stuff is first.
Oh, okay.
So if you keep scrolling, then you should be able to find it. Did you find it?
Mm-hmm.
Okay.
So we start with the nasal cavity?
Yeah, or if you're going to go through the mouth, you can go oral cavity to oropharynx and then keep going down. Depends on which way the air enters. Mm-hmm. Like, unfortunately, I'm a mouth breather, so it's all going through my mouth. Who still needs time with this slide? Okay. Okay. So just so you know, and we're going to have a model that shows this today, and I'll go over it with you all in lab today. But even though it's not the last part of this system, terminal bronchioles are first, and then they lead to respiratory bronchioles. And then once they are inside the alveolar sac, it becomes an alveolar duct, which is then going to serve the alveolar sac and then the individual alveoli. So terminal first. That the terminal bronchioles come first, and then the respiratory bronchioles. Once that tube gets inside the alveolar sac, the bunch of alveoli, then it's called an alveolar duct. And that's going to serve the sac as well as the individual alveoli. Mm-hmm. Okay, so now we're going to talk about pressure changes and relationships. So volume changes can cause pressure changes, which can cause air to move. So just like chemicals, we talked about equilibrium a lot in BIOL 32, and how for diffusion, and most of the time, things go from an area of high concentration to an area of low concentration to meet equilibrium. Same thing works for air and pressure. So air is going to flow from areas of high pressure to areas of low pressure in order to reach an equilibrium as well. So air moves into the lungs when the pressure inside the lungs is less than atmospheric pressure. So once, and we'll talk about all the changes that are made. So when you exhale, and when you blow air out, or actually no, let's talk about inhale. When you breathe air in, what's going to happen first before the air moves in is your chest and your rib cage is going to move out and upward. Okay, so your chest cavity moves up and out, out, outward and upward. And then also, if you remember from B32, this is your diaphragm when it's relaxed, and then it's flat when it's contracted. So when you breathe in and right before you breathe in, your diaphragm contracts, your rib cage moves outward and upward, and it creates more space in your chest cavity. And so the more space that you have, the more volume you have, that actually lowers the pressure. We'll talk about that relationship in the next slide. But you lower the pressure in your chest, and then air can move in. Okay? And it may not seem like it because it seems like it's all happening at the same time, but the pressure changes actually happen first, and then the air moves. You open up your rib cage, that lowers the pressure inside your chest, and then the air moves in. Okay? So you have to set up the stage before air can move in. And so air moves into the lungs when the pressure inside the lungs is less than the atmospheric pressure, the pressure around you. And so how is this accomplished? What is the process of breathing in? What's that called? Inhalation. Or you can call it inspiration. And so when you breathe out, and before you breathe out, hey, your rib cage actually goes back in and down. Your diaphragm goes back relaxed. And now that you have less space, the pressure increases, and then the pressure inside your chest is more than the pressure outside. So now the lower pressure is on the outside of your body, and then air can move outward. Okay, because air is always going to follow the lower pressure. Always, always. And so what is that process of breathing air out? Exhalation or expiration, either one. And we'll talk more about like atmospheric pressure later on in the lecture, but atmospheric pressure is created by all the different molecules that are in the atmosphere kind of bouncing off each other and bouncing off all the surfaces around you. So there's nitrogen in the air, there's oxygen in the air, there's carbon dioxide in the air, there's water in the air. And as all those things are bumping off of each other and off of the surfaces all around you, they create a pressure around you called atmospheric pressure. And sea level, normal atmospheric pressure is 760 millimeters of mercury. This should already be in your lecture notes, which is equal to 1 atmosphere. And that's just another unit for measuring pressure, but they mean the same thing. That is your average atmospheric pressure. And so what millimeters of mercury really means is that how they used to measure pressure, they still do with like manual blood pressure readings, is there's a tube of mercury. Okay? And what that means is that the pressure in the atmosphere is able to push the mercury up a tube 760 millimeters, which is why it's called millimeters of mercury. And so this is kind of how that atmospheric pressure works. I want you to jump in your notes to the section that talks about Boyle's law. We're going to jump around a little bit, but on the next page, there should be a little section that mentions Boyle's law. Bottom of 99. Okay. So movement of gases follow Boyle's law. So this means that volume and pressure are inversely related. So again, during inhalation, your thoracic cavity volume increases, intrapulmonary pressure decreases, and the air flows into the lungs. So what you're doing is you are essentially creating more space. So right before you breathe in, again, your rib cage moves outward and upward, creating more space. Your diaphragm goes from a relaxed state to a contracted state, again, creating more space. So if we're looking at just the diaphragm, I guess I will do that. This is when it's relaxed and you have this much air in your chest. Right before you breathe in, when you contract your diaphragm and it stays flat, now you have this much space for air. So what ends up happening is that the more space that you give these molecules to move around, like oxygen and carbon dioxide, the more space they have to move, the less often they bump into each other and bump into the walls, and so it's a lower pressure. Okay? And so when you contract your diaphragm, move your rib cage out, that's going to lower the pressure inside your chest cavity. So now your chest pressure is lower than the pressure in the atmosphere on the outside, and air follows the lower pressure and moves in. Okay, does that make sense? Okay. During exhalation, when you go back to the relaxed state and it's like this, and there's less room for those molecules to move around, and you can see here, they're going to bump into each other, those molecules of oxygen, nitrogen, all these other molecules, okay, carbon dioxide. They're going to be bumping into each other and the surface of the thoracic cavity a lot more often, which is going to create more pressure as they are colliding with each other more often. And so during exhalation, when your diaphragm relaxes, your rib cage moves back in, your thoracic cavity volume decreases, so your intrapulmonary, or the pressure within your lungs, increases, so now your chest cavity pressure is higher than what's on the outside. So the lower pressure is out here, and air follows the lower pressure out. Okay. So there's an inverse relationship between volume and pressure, and that's what Boyle's law is all about. The higher the volume, the lower the pressure. The lower the volume, the higher the pressure. All right. I always compare it to like the beginning and end of a vacation. When you fill up a suitcase at the beginning of a vacation, lots of room for the clothes in there. They're all nice and neatly folded, right? It doesn't really take a whole lot of pressure to close that suitcase. But by the end, it's all kinds of stuff. And you have to be sitting on your suitcase in order to close it all up. You need a higher pressure because there's less room for those clothes to move around. Okay. So this is kind of a complicated process, so bear with me here. So we're going to talk about the different pressures within our respiratory system. So whenever we talk about pressures of the lungs, respiratory pressures are always described as relative, or we compare it to atmospheric pressure. So a big P is for pressure, the little ATM means atmospheric pressure. So whenever we talk about pressures within the lungs, we always relate it back to our atmospheric pressure, the pressure around us. So a couple of terms that we use. When we have a negative respiratory pressure, that means that the pressure is less than the atmospheric pressure. When we have a positive respiratory pressure, that means that the pressure that we're talking about is greater than atmospheric pressure. And we are said to have zero respiratory pressure if it's equal to atmospheric pressure. So the first thing to know, and I already mentioned it, is that atmospheric pressure at sea level, which it might be a little bit different for us. We're at the top of a hill here at BC. But once you get into the mountains, you're going to be at a much lower pressure. And we'll talk about elevation and lower pressures and respiratory too. But the atmospheric pressure at sea level should be 760 millimeters of mercury. And so that 760 millimeters of mercury acts as our baseline. Okay? And so what we do is we set that to 0. Okay, so because it's our baseline, we're going to be going above and below that, and we set it to 0 because it's a lot easier to add and subtract a few numbers from 0 than it is from 760. Okay, because then the math gets kind of weird and it's hard to keep track. So we set our baseline at 0. That is equal to 760 millimeters of mercury. And we're just going to see how much do we go above that and how much do we go below that. Do we go positive or do we go negative? And it's only going to be by a few. And so we'll talk about inhalation first. For inhalation, okay, pressure is going to decrease. The pressure inside your lungs is going to decrease and be less than that atmospheric pressure to allow the air to follow the lower pressure and come inside. And so when the pressure decreases lower than our atmospheric pressure, we call that a negative pulmonary pressure, or P-pull. Okay, because it's lower than our baseline. And we do this via a flattened or contracted diaphragm and pulling out the rib cage. So again, by going from a relaxed to a contracted position, by pulling out the rib cage, that creates more space, more volume, and the pressure decreases. And anytime we go lower than atmospheric pressure, which we have now set to 0, that is now considered a negative pressure. Okay, and P-pull stands for pulmonary pressure or intrapulmonary pressure. So PATM is atmospheric pressure. P-pull is intrapulmonary pressure, the pressure within the lungs. And I'll give you one more in a little bit. I can erase this stuff on this side. You guys have written that down already? Okay. Ooh, go back.
Can you go back? I'm so sorry.
No, yeah, I'm gonna be there. It accidentally went away. I'm staying here for a little while. Mm-hmm. So then we move on to exhalation. And during exhalation, pressure inside the lungs increases, my bad. Increases, and it's going to increase above that atmospheric pressure, which is going to create a positive intrapulmonary pressure. And how we increase the pressure is by moving the diaphragm back to that relaxed position, bringing the rib cage back in, so there's less volume, there's less space, and therefore a higher pressure. So this happens by the upward movement or relaxing of the diaphragm and pushing in the rib cage. And when this happens, you're increasing that pressure inside the lungs. So now it's greater than atmospheric pressure, high pressure in the chest, low pressure outside, and then air can be pushed out. So this pushes air out. Over here, when we were talking about inhalation, this pulls the air in. Okay, any questions on inhalation and exhalation before I move to the next thing? Okay. Now, can I erase this side? Okay. So now we're going to talk about one more pressure. Intrapleural pressure. Which the abbreviation we use is PIP. So the intrapleural pressure is the pressure inside the pleural cavity. So in between your visceral and parietal layers, that's the pressure that we're talking about. And this is always about 4 millimeters of mercury less than our intrapulmonary pressure. So it always needs to be less than the pressure that's inside the lungs. You remember when we talked about like cardiac tamponade, and when there's extra pressure around the heart that it can't contract? It's going to be the same thing with the lungs. If we have more pressure around the lungs can't inflate and deflate. They're not going to be able to. So that intrapleural pressure needs to always be a little bit less than the pressure inside the lungs to prevent the lungs from collapsing. It creates kind of like a suction as it pulls on the lungs as it inflates and deflates, which keeps the lungs expanded and doesn't allow them to collapse. So PIP, or intrapleural pressure, is always negative compared to our intrapleural pressure, or the pressure inside the lungs. So you see how it's -4 here. When it's 0 here, it's going to be that all the time. It's always going to be -4 inside that pleural cavity compared to what's happening inside the lungs. It always has to be slightly lower. And again, this is to prevent lung collapse. So any questions about those different pressures? Okay. There are some great YouTube videos that talk about the differences in pressure and how the lungs move. If I find some time today, I'll send some links to you guys so you can go back and review. Or you can watch this over and over again, but it's always good to hear explanations from different people. But I'll try to find some to send to you well. So when these pressures get disrupted, so like I said, that intrapleural pressure, the pressure inside the pleural cavity, always has to be slightly lower than the pressure inside the lungs. If it's ever equal to or more than the pressure in the lungs, that lung is going to collapse. Okay, and so the collapsing of a lung is called atelectasis. So atelectasis is the clinical or scientific term for a collapsed lung. And you can see here this deflated collapsed lung on the left side. This can happen one of two different ways. So the pressures can be disrupted if a bronchiole becomes plugged. And for it to be considered a bronchiole, how big does its diameter have to be?
Less than 0.5 millimeters?
Less than 1, but your bronchioles at the very end are about 0.5. Yeah. So bronchiole becomes plugged, can cause a collapsed lung, like in the case with pneumonia. So what happens with lung collapse in lung disorders like pneumonia? What happens is the alveoli absorb all the air within the individual sac and they collapse. So remember your alveolar sacs, one, there's a lining of water within it. And anytime you have water in an enclosed space, that water is pretty attracted to each other. Okay? But your lungs do create that surfactant, okay, which lowers surface tension. And so it keeps it nice and big and open so the water doesn't want to come together. Okay? So your alveolar sacs are getting bigger and smaller all day long as air is moving in and out. But if at any point the bronchioles become plugged and and there's not enough air movement and all of the air inside the alveoli gets sucked out, well, now those walls are going to be so close together that they are going to collapse. And if they all collapse, then the whole lung is going to collapse. Okay? So it can happen because of that. And also can happen, which we'll talk about next, because of a pneumothorax, which is a puncturing of your chest and pleural cavity.
So what, Professor?
It's when you have a puncture or a rupturing of your pleural sac, of your parietal and visceral pleura. So a pneumothorax can happen in a couple of ways. It can be from a puncture wound. So if you were to get stabbed in the chest or be in some kind of car accident where something punctures you in the chest, okay, that's going to allow fluid and air to get into that pleural cavity in between the layers of your pleura or serous membrane. And not to give or unlock a new fear in anybody, but it can spontaneously rupture as well. It can also sometimes be caused by medical procedures as well. But these are the two that your book focuses on. So either by a puncture wound, or it can happen spontaneously that the visceral pleura ruptures. Well, when that happens, you're introducing either air or fluid or both in between those two layers of your serous membrane. And when that happens, this is no longer going to be for less than what's inside the lungs. Because now you're introducing more fluid and air into that space, which is going to increase the pressure. Yes, Caitlin?
Did you mention how the bronchioles can become plugged?
Yeah.
How that happens?
Oh, so with like pneumonia, you have lots of mucus build up and then air can't move.
Okay.
It could be even something small where you choke on something and air can't move. Okay? But mostly it's going to be things like pneumonia that cause excess mucus and excess fluid that doesn't allow air to move in and out. So again, from a puncture wound or from rupturing, now you've introduced air, fluid, or both in between the walls of your pleura, in between the visceral and parietal layers, which is going to increase the pressure. And once the pressure is equal on both sides, there's no longer going to be any movement of air and that lung is going to collapse. So it's always really important that the intrapleural pressure is always 4 less than whatever is inside the lungs at all times. So you can say pneumothorax. Is the presence of air, or it could be fluid as well, in the pleural cavity. A treatment for this would be a chest tube to draw out the air and then lower that pressure.
Lower the hip or
No, PIP, yeah. Okay, any questions about a pneumothorax? Okay. So now you're going to skip over the Boyle's Law notes we already went over, and now you're going to go on to pulmonary ventilation, where we talk about inspiration and expiration. And again, you could call it inhalation as well. I don't care which version that you use. But, and this is all happening in order, the diaphragm contracts and flattens. The muscles lift the rib cage upward and outward. So your chest cavity and lung volume now increases now that there's more space. And then the atmospheric pressure ends up being greater than your intrapleural pressure. Because now you've opened up all this space, more volume, which means less pressure. And so this creates a negative P-pull. And so now that the air inside the lungs, or the pressure inside the lungs, is less than the pressure on the outside, air is going to move in. And you can try to breathe a million different times to see which one happens first, but it's all happening so fast you can't really tell that the chest and the diaphragm are moving before the air moves. All right, so again, inspiratory muscles are going to contract, so the diaphragm descends or flattens, rib cage rises, thoracic cavity volume increases, the lungs are stretched, and so the intrapulmonary volume increases as well. So your intrapulmonary pressure now drops because now we have a higher volume. Now it's going to be a negative P-pull, and then the air flows into the lungs, right, in that order. Expiration or exhalation is going to be the opposite. The diaphragm is now going to relax and go back to being a dome shape. The muscles bring the rib cage back downward and inward. Chest cavity and lung volume decreases. And so now the atmospheric pressure is now the lower pressure, or the less pressure, because now you've just lowered the volume inside your chest, and so pressure increases. So now you have a high pressure in the chest, lower pressure in the atmosphere, and air is going to rush out. And this creates a positive P-pull. And then air rushes out.
so your PIP is constantly accommodating.
Mm-hmm. So no matter which way that the P-pull is moving, it's always going to be -4 behind it as it's going up and down. So again, inspiratory muscles relax, and so the diaphragm rises. Rib cage descends due to recoil of coastal cartilages. So then the thoracic cavity volume decreases. The pressure inside your lungs also, or volume inside your lungs also decreases, which is going to increase the pressure inside the lungs. So now we have a positive P-pull, and the air is going to flow out of the lungs. So everything gets smaller, pressure gets higher, and air is forced out. So the skeletal muscles that are going to help with your breathing. So first you have just quiet breathing, which is what most of us are doing right now, as we're just kind of, well, y'all are relaxing, but So while you're sitting or you're at rest, okay, you're doing quiet breathing. And so the only muscles that are helping with quiet breathing are going to be your diaphragm and then your external intercostals. Their contraction and relaxation leads to inhalation and exhalation respectively. This is just quiet breathing. When you have a forced inhalation though, you take a nice deep breath in, okay? That's forced inhalation, and so because you're doing a more forceful inhalation or breathing, you're gonna have to recruit more muscles to help with that. And so that's going to include your sternocleidomastoid, that's on your neck, your pectoralis minor, and some other accessory muscles too. So you're using more of your chest and your neck, okay, to help with that forced inhalation. And then forced exhalation, same thing. When you blow out the candles for your birthday and you blow out whatever extra air that you have, you're also going to have to recruit more muscles to do that. That includes your internal intercostals, your abdominal muscles, and some other accessories as well. Now, don't do too much breathing, trying to figure these things out, or else you're going to get lightheaded, yes. All right, so just know the differences between quiet breathing, forced inhalation, and forced exhalation, and which muscles are involved. All right, so we're going to talk about some physical factors that influence ventilation or the movement of air in and out of the lungs. And so first of all is the diameter of the bronchioles. What can change or influence or disrupt the natural diameter of the bronchioles are irritants and allergies, things that you're allergic to. Now this is all already in your notes, but you actually have a parasympathetic reflex that gets activated when you inhale an irritant or something that you're allergic to. This is going to cause really aggressive constriction of your bronchioles if you're irritated by something that you're breathing in, and that's going to reduce your airflow. Okay? So anytime you breathe in an irritant or something you're allergic to, your bronchioles are going to constrict, and that's a parasympathetic reflex. Okay? And that's going to reduce the amount of airflow that's coming in. Now, another thing that affects bronchial diameter is asthma. With asthma, you already have constricted airways and mucus buildup. And when you have an asthma attack, it's even further constricted than what it already is. And even more mucus can be created, which makes it really hard to breathe. So during an asthma attack, histamine gets released, which is an inflammatory chemical, and can cause really, really strong bronchoconstriction. And why it's so dangerous, an asthma attack, is that it can actually completely stop ventilation by how much the bronchioles are constricted during a really severe asthma attack. And so this is when you would need maybe an EpiPen, because what an EpiPen or an epinephrine is going to do, it's going to dilate those bronchioles back up. And the more that you open up those bronchial diameters, you decrease the resistance to airflow and more air can come in. And then remember, epinephrine on the bronchioles for dilation, it's going to be a beta-2 receptor. Normally, anytime it's the number 2, it's going to be an inhibitory receptor or something that's going to cause relaxation. When they use a number 1, like beta-1 and alpha-1, it's usually excitatory. So for epinephrine at the lung, specifically at the bronchioles, it's going to be a beta-2 receptor that causes dilation, that opens up the airways and allows that person who's experiencing the asthma attack to breathe much more easily. Another thing that influences ventilation is something called alveolar surface tension. And so, is it type 1 or type 2 alveolar cells that make surfactant? Type 2. Type 1 is involved in gas exchange. Type 2 makes surfactant. So type 2 alveolar cells secrete surfactant to prevent alveoli It makes it so that the water inside the air sacs are not as attracted to each other, and so when the air sacs get smaller, the walls don't want to collapse on each other. So there is a disorder called ERDS, and this should already be in your notes. I think it stands for Infant Respiratory Distress Syndrome. And so when this happens, it's usually because the baby is premature. So premature babies that are not producing enough surfactant may experience ERDS. And that makes it really dangerous because these air sacs start to collapse and the lung can collapse. And so how we can treat that and prevent these premature babies' alveoli from not collapsing is we can actually administer a surfactant spray. So you spray the inside of the respiratory tract. That spray goes all the way down to their alveoli, coats the alveoli, and keeps those alveoli nice and open. You can get, or they can be administered a natural surfactant that would come from maybe an animal, or it can be synthetic as well. Both are manufactured. You can also prescribe antenatal, which means after birth, corticosteroids. What steroids can do is they can speed up development. And so if you prescribe corticosteroids to a premature baby, it can help with their development to happen much quicker, so that maybe those alveolar cells, those type 2 alveolar cells, will start to produce their own surfactant sooner. And so it helps the baby speed up the process. There is another form of respiratory distress syndrome that does not have to do with surfactant or premature babies. It actually affects adults. And it's called ARDS, which is adult respiratory distress syndrome. And this usually happens because of gas exchange problems. There's something that's not allowing gas exchange to happen properly. And this could be due to something like a near drowning. If you inhale anywhere from 2 to 3 ounces of water due to a near drowning, then that can cause ARDS, where you're going to have some problems with gas exchange because there's too much water in the lungs and air can't move properly. Or also, firefighters many times can experience ARDS because of smoke inhalation, and the smoke inhalation causes the gas exchange problems. Yes?
In children, would it be considered ARDS, like if, like, a non-infant?
It doesn't, no, because usually this is for adults. I don't know if there's like an in-between a child's respiratory distress syndrome. I have to look it up. But that would have to be specifically for adults. We wouldn't use that for a child. But I'll look into it. Oh yeah, so if you have a near drowning and you inhale 2 to 3 ounces of water, so 2 to 3 ounces get inside your lungs, then it can cause gas exchange problems that lead to ARDS, or respiratory distress syndrome, for adults.
So for firefighters, it's because of inhalation and smoke?
Yep. Okay. Can I erase that stuff now? Okay, so what I wanted to show you I forgot to move on this one, so I can show you this. Oh, no, where did it go? I thought I had... No, I think maybe I bring that up later when we talk about... Oh yeah, never mind. I lied to you. We'll talk about asthma again later, so I can show you the airways. But we're going to talk about compliance next. So compliance is the stretchiness of your lungs. Okay, so how much can your lungs stretch? And this First of all, if you are considered to have high compliance, that means that you have an easy time expanding your lungs. Okay, and just like we have a supportive stroma in our lymphatic system, we also have a stroma in our respiratory system. The stroma in this case, though, its job is to make elastic fibers that contribute to the compliance. The more elastic fibers that you have, the more your lungs can stretch, the more compliance that you have. And your compliance will lessen with ossified cartilage, which this is common to occur once you get older. As you get older, your cartilage is going to harden. So this is common with old age. And then you can lessen your compliance also if you have damage that leads to fibrosis, where your elastic tissue is being replaced with other connective tissue. And this can be due to exposure to toxins. This might already be in your lecture notes already, but exposure to toxins, chemotherapy as well, because chemotherapy is going to damage all cells body-wide, not just the cancerous ones. So this includes your elastic tissue. Certain medications can cause fibrosis as well. Specifically medications that treat the heart, sometimes antibiotics, and anti-inflammatories. These have all been known to lead to or make fibrosis more likely to happen. Also, it could just be your genetics as well. Some people are more likely to experience fibrosis as they get older just due to genetics. Okay.
What does the ABO stand for again?
Antibiotics.
Okay.
I only had this much room to write antibiotics. So any questions about compliance? Okay. I want y'all to skip over the part about respiratory volumes and capacities, because that's a lab thing that we can cover tomorrow if needed. I want to go over partial pressure first, so skip over respiratory volumes and go to partial pressures. After that empty graph, it'll talk about partial pressures. So I can pick up the respiratory volumes in lecture tomorrow, or at the very least in lab tomorrow, because that's when we're going to go over respiratory volumes anyways. My God, Monday. I won't even be around tomorrow. So yes, Monday. Sorry.
No short.
Sorry, my bad. Okay. So first of all, there's another law, and you want to make sure that you get these two correct. Boyle's law is that inverse relationship between volume and pressure. The higher the volume, the lower the pressure. Lower the volume, higher the pressure. That's Boyle's law. We also have Dalton's law. Dalton's law of partial pressures just means that the total pressure, that our total atmospheric pressure equals the sum of the pressures from individual gases. And these pressures from the individual gases in the atmosphere, these are all considered partial pressures. And so you need to be able to calculate a partial pressure. So how we do that is here are the different percentages for these different partial pressures. So we have nitrogen gas, then we have oxygen gas next, then we have CO2, and then water. These are all the percentages for those different gases in the atmosphere at sea level. Okay. Now, in the event of an exam, and if I were to have you calculate partial pressure, you would be given the percentages. You don't need to memorize them. What you need to know is how to do the calculation. Yeah.
You said that's sea level?
This is at sea level, yeah. And so how you calculate a partial pressure, because if you remember, what is our atmospheric pressure? 760. So let's use oxygen first. Oxygen is 20.9% of our atmospheric pressure, okay? We need to turn that into a decimal first before we can multiply it out. And how you do that, how you divide by, we divide it by 100, or you can do a shortcut and just move that decimal place places to the left. That's the same thing as dividing by 100. Just move it 2 places to the left. Or on an exam also, you're going to have a calculator, so you can just do 20.9 divided by 100. Okay. So you're going to move the decimal place over 2 times, which means that you're left with 0.209. And in order to calculate the partial pressure, all you do is multiply that by your total pressure. How much pressure is 20.9% of what our total pressure is? And when you multiply those 2 numbers together, you should get around 159 millimeters of mercury. Is everybody comfortable with that? Another example, we'll use nitrogen. 78.6%. Again, divide by 100, which you just move the decimal place over 2 times to the left, which is equal to 0.786. Multiply that by 760, and you're going to get about 597 millimeters of mercury. So that's how you calculate partial pressures. And if you were to add all of those partial pressures together, you should come up with 760. Yeah, total pressure, yeah. Any questions about that? Okay, so what we're going to cover a lot tomorrow, I'm going to go over it, on Monday. Don't be here tomorrow. What we're going to go over on Monday in great detail is this diagram. So one of the things that you're responsible for is knowing the partial pressures of oxygen and carbon dioxide throughout the cardiovascular system, okay? So in the pulmonary arteries, in the systemic arteries, pulmonary veins, systemic veins, what are the partial pressures? Luckily for all of you, they follow a certain pattern, and so we'll talk about that as we go along. We can ignore nitrogen gas because we don't use that metabolically. Okay, the nitrogen that we use metabolically, we get from food sources. Water as well. We don't use the water that we breathe in metabolically. We use the water we ingest. Okay, so we can ignore water, we can ignore nitrogen. We're just going to focus on oxygen and carbon dioxide, the actual gases that are exchanged at the lungs. So in the inspired air that you breathe in the atmospheric pressure, stop moving around. And your atmospheric pressure. Partial pressure of oxygen is 160 millimeters of mercury, which is what we just figured out was 159. We'll round to 160 to make it easier. And then the partial pressure of CO2 in the atmosphere is 0.3 millimeters of mercury, which I'm okay with you rounding to 0. If that's easier to remember than 0.3, you can just say 0. So these are just at sea level all the time. Partial pressure of oxygen is always going to be 160. Partial pressure of CO2 is always going to be around 0. Now, once you get to the alveoli of the lungs, so inside the air sacs, the partial pressures of these are going to change a little bit because inside your alveoli, you're going to have new air that's coming in and old air that was already left behind. So you're going to have mixing of old air and new air. So these numbers are going to change. So now the partial pressure of oxygen inside the lungs is 104. This is just inside the individual alveoli. And the partial pressure of CO2 is 40. And again, that's due to a mixing of old and new blood. Then we have gas exchange at the capillaries of the lungs. We're going to bring oxygen into the bloodstream. We're going to get rid of CO2 back into the lungs to breathe it out. Once we have exchanging of gases here, and now we're in the pulmonary veins. Now we have oxygenated blood here because we already exchanged gases. Partial pressure of oxygen is going to be 100. It doesn't stay at this 104 up here because gas exchange is not perfect. We're not going to get all 104 of that pressure inside the blood. It's going to change a little bit. Okay, so due to insufficient diffusion, that partial pressure of oxygen drops a little bit. So we're at 100 inside the pulmonary veins. And our partial pressure of CO2 is 40. So from there, from the pulmonary veins, the blood moves through the left side of the heart, out the aorta, and now we're at the systemic arteries. From the pulmonary veins to the systemic arteries, has any gas been exchanged between the blood and the atmosphere? No, right? So that pressure is going to stay the same. Systemic arteries and pulmonary veins both have a PO2 of 100 and a PCO2 of 40. So one thing I'm going to forewarn you about on your next exam, I can point to or tag any artery or any vein and ask you, what's the partial pressure of oxygen? What's the partial pressure of CO2? But know that anytime you're looking at an oxygenated vessel, so anytime the vessel is red, because that means it's oxygenated, the partial pressure of oxygen will always be 100. The partial pressure of CO2 will always be 40. That will never change. So this is where you can rely on color in an exam. That's usually not the case. Okay, when we name arteries and veins, you really don't want to rely on color because sometimes the pulmonary arteries are blue and pulmonary veins are red, but in this system it's different, right? This is where you can rely on color. Anytime you see an oxygenated vessel, which is always red, PO2 is always 100, PCO2 is always 40. Now, we get to the tissues down here. Your PO2 is less than 40. PCO2 is greater than 45. If you remember, air always wants to follow the lower pressure. So if this is the tissues and this is our oxygenated vessel, the oxygen is going to want to move to the tissues. Because we have 100 in the blood, only 40 at the tissues, and so air wants to follow the lower pressure, which makes sense because at the capillaries at our tissues, the whole job is to deliver the oxygen, right? So we're giving oxygen to the tissues, and then CO2 is 40 here, and CO2 is 45 at the tissues. So this is how we get rid of the CO2, and we put that in the blood. We're giving the oxygen to the tissues, and we're picking up their CO2. So when we go to the other side, over here in our systemic vein, oxygen will now have dropped because we just delivered oxygen. So there's going to be less oxygen in the blood. It drops down to 40. And we just picked up CO2, so that pressure is going to go up. And that's 45. And so we're going to go through the right side of the heart, through the systemic veins, through the right side, out the pulmonary trunk into the pulmonary arteries. From the systemic veins to the pulmonary arteries, has any gas been exchanged? No. And so anytime you see a blue vessel, PO2 is always going to be 40. PCO2 is always going to be 45 for every single deoxygenated vessel. Okay? And then we start all over again back at the lungs. Now that was just a quick run through. We're going to go through this again step by step, and you're going to write down all the pressures when we come back on Monday, not tomorrow.